two excellent talks today. On behalf of the ISHKS board, the trustee, Dr. Vikram Shah, our president, Indrajit Sardar, our secretary general, Dr. Dr. Pachore, and my co-chair, Dr. Dipak, I welcome you all. We have two excellent talks, one by Dr. Sathish Devadoss and other by Dr. Vikash Kapoor. Dr. Sathish Devadoss is a consultant at orthopedic surgeon doing orthoplasty work at Madurai. He is also the membership chair of the ISHKS for the past 2 years. And he's going to talk about conversion orthoplasty, conversion of failed hemiorthoplasty, proximal femur fractures, complex topic. And he has done a lot of work in hip and knee orthoplasty. And I welcome you all once again to the program. I invite Dr. Sathish to give his talk on conversion hip orthoplasty, tips and tricks.
Thank you, Dr. Dhanasekar. Good evening, Dr. Indrajit Sardar, Dr. Pachore, Dr. Dave, and Dhanasekar, and all the people listening today. It's indeed a pleasure to be here today to be presenting on a very one of my favorite topics, which is conversion THR. Is my slides visible?
No, Dr. Sathish, no.
Not yet, sir?
Now it's seen, Sathish.
Yeah, okay. So, conversion THR is a terminology given to hip arthroplasty when it is done once there is a failure of some other procedure. Typically not a revision, because revision is from failed primary to a revision, but this is from a failed prior surgery, probably due to trauma surgery, or it may be due to even a unipolar or a bipolar prosthesis. So why is there increase in number of these today? Because we know our life expectancy has gone up very much. The hip fractures in the elderly are definitely on the rise. Proportionately, there is an increase in the hip surgeries. So, but definitely statistics will have to tell us that there will be quite a bit of complications also. And many of these patients end up with complications. So this may lead to disability in many individuals. Today, young and old are required to be mobile and to be active because in the society today, everybody needs to be independent. So there is a need for a conversion total hip replacement in today's practice for an arthroplasty surgeon. Now, what are the fracture complications in THR, in fracture complications in the hip? Usually there is non-union, malunion, infection, hardware failure. We see that a lot nowadays, avascular necrosis following fractures, then post-traumatic arthritis, secondary to faulty fixation, or maybe due to avascular necrosis could be the reasons for the complications for proximal femur fractures. Again, the failure rate of screw fixation has been between 5% and 6% after 1 year, and it increases to about 10% at 5 years. So these are the statistics. So that's another study. They say the most common reason for conversion total hip replacement was due to avascular necrosis of the femoral head, nearly 44%, and post-traumatic degenerative changes, arthritis is about 35%, and non-union neck of femurs or trochanteric fractures can also be there. It comes to around 21% according to some of the study. So why is this being discussed? What are the challenges we are facing due to this problem of this proximal femur fractures? So the challenges are, first, we'll take it from each and every fracture perspective. Failed IT fractures are one of the most common procedures where we do the conversion THR. The failure rate of fixed IT fractures up to around 1.2 to 9.6%. This may lead to coxa vara, loosening of the implants, or even breakage of the implants, severe hip pain because of the cutout of the implants, loss of hip function, and patient may be on using physical aids to walk. So surgery of the failed internal fixation, maybe you can do a refixation, especially in the young, with some bone grafting and another form of fixation. But in the elderly, we cannot go on and do many more surgeries. So conversion hip arthroplasty may be the only option in this elderly, where the bone is also very weak. There may be damage to the acetabulum due to the screw cutout, whether it is gone inside or it has been causing some erosion of the bone. So conversion THR is the only option in the elderly. So the other challenges are, the first major challenge I would say is to remove the hardware. So many times the hardwares, the screws, threads may be gone, the screw head may be gone, broken screws may be difficult to remove, maybe time consuming to remove. And there is, again, when you are trying to remove also, there is a risk of fracture of the proximal part. Then your plan for the surgery may be changed. So maybe you must be very careful in doing all this. And the approach needs to be modified. Many of the times, DHS may be done on the lateral approach, and when the patient is on a fracture table, so the approach may be totally different from what you're going to do for a total hip replacement. And potential damage to soft tissues and neurovascular structures while trying to remove it. If there is again presence of other metal, especially in acetabulum fractures, there is a chance for fibrosis, and maybe you may be damaging the sciatic nerve also. Again, the other challenges here, the bone quality is compromised. The bone is very thin. Many times because of the cutout, there is osteopenia, osteoporosis. The bone loss may be present because of this. And definitely there is altered anatomy because of previous surgeries, because of the failure of the implant, failure of the surgery. There can be altered anatomy, malunions, non-unions, which you must be aware of. And this, again, is one of the major challenges of this surgery. Coming to the patient factors, many of them are elderly, older patients. So there is compromised general health, comorbid conditions. Many times that there may be the reason also. Poor nutrition, poor albumin status may be a reason for failure of this also. Decreased bone quality, osteoporosis, vitamin D deficiencies. All this can lead to poor bone quality, and also because most of these are elderly patients, you need to have a multidisciplinary approach. When you're selecting the femoral stem, be careful that you need a long femoral stem where you need to cross the screw holes. Aim for a distal fit, and if you're using uncemented, most of the time you'll be getting away with a distal fit stem, especially if it's a trochanteric fracture or a fracture neck of femur. But again, keep long cemented stem also handy. It's better you go with all your armamentarium for a total hip replacement when you're going for such difficult surgeries. Cemented stem allows for immediate mobilization. That's an advantage in the elderly. Be careful and use cables and wires to reattach the trochanter. And if you're using a trochanteric osteotomy, extended trochanteric osteotomy also, you may need to use those cables and wires. Again, order the right implants. Have calcar replacement if you have an IT with a huge lesser trochanteric fragment which has become a non-union. You may need a calcar replacement processes. Always use for a long stem. You may go in for a cemented or uncemented. Many times, if the head is not present, you may need to order for allograft also. Many times, where you may need to, when there is bone loss in the proximal part, better to keep some allograft, and bone graft also be prepared. have on the cup side, have a multi-hole cup. Either you may be able to use a dual mobility or constrained liner, because the soft tissues are also damaged here, and you may not get the adequate tension in the soft tissues. So keep dual mobility, or if required, a constrained liner also ready. In the preoperative planning, as usual, we need to do all the tests. A very important thing in elderly individuals is to do protein levels, albumin. If it is less, better to make sure the patient is given adequate proteins. Otherwise, healing and rate of infection may be higher. If there is infection suspected, aspirate the joint, cell counts and culture has to be done. And X-rays and CTs may be needed to assess any defects in the bone, and if there is an acetabulum issue also, then a CT scan will be definitely mandatory. Again, evaluate the limb length. You need to correct it after the surgery. Coming to specific conditions, when there is infection, usually when there is infection, when there is implant inside, you remove the implant, debride. It has to be a two-stage procedure. You can put an antibiotic spacer or cement beads. And in terms of long-term antibiotics, has to be given intravenously up to even 6 weeks. And then once the CRP comes to normal, then only you can do the total hip replacement. So stage 1 needs a thorough debridement and antibiotic spacers. So this is one example of a young man who has had multiple surgeries, and you can see the head is almost resorbed there, and so many surgeries, deformed proximal part of the femur. So in the first stage, we have done cement beads there. And on the second stage, we had put a long stem, but because the proximal part was fairly strong, and a young person, I had used the SROM prosthesis here, and we managed to do a good job here. This is a case of acetabulum fracture, which had also had sinus and infection. First stage, we had put in a cement spacer, and the cement spacer, antibiotic cement spacer was done after debridement. After 6 weeks, we went on to do a hybrid kind of a fixation. It was an elderly gentleman. So we kind of mobilized him early and put a hybrid total hip replacement. This is another elderly lady with a kind of a basic cervical fracture. Probably this could not have been a right implant. DCS has been used, and a patient came to us at this stage, and we revised it with a distal low fixing stem. So here, very important, proximally fixation is not going to be very good. So distal fixing stem is like this device here. The solution stem here I've used. You can use whatever you're comfortable with, probably a Wagner or any other stems of that kind, similarly also. And here we had used a calcar replacement prosthesis, and wiring was done proximally so that if there is any splintering, it should not propagate. So those are also some points where you need to do for these kind of elderly patients with fractures non-union. So this is a patient, this is done more than 10 years back. She's doing pretty well. And many times, young patients, physiologically young patients have been given Austin Moore prosthesis, and you'll need to change them also because they don't last for more than 1 or 2 years, and patient gets pain. And this is a conversion THR for Austin Moore prosthesis. Here, the challenge is going to be dislocation of the prosthesis. So be careful. You may, if you don't get proper dislocation, may need to do an extended trochanteric osteotomy and fix it. This is another situation where the head is almost resorbed. The DHS is cut out and it's hitching on the acetabulum, and there is malunion of the trochanteric part. So be careful on what you are going to do. Plan everything ahead. You will probably need to do an osteotomy of the trochanter and then remove the metal, have a long stem. Here again, I have used a long solution stem. So the osteotomy has been done and the fixation has been done. And in this long femoral stems, you will have to have at least 4 to 6 centimeters of good purchase distally. So this patient also went on to do well. Such scenarios probably are not seen very much nowadays, but many times we see a lot of these excision arthroplasties have been done for tuberculosis or sometimes even for some fracture neck of femur, where the head and neck are completely resolved and there is a very high riding trochanter. So here we need to plan how to bring the trochanter down, or do we need to do a femoral shortening? Here again, we went on with the plan of a femoral shortening, but luckily we were able to get it down. And here, long stem with the SROM stem has been utilized. Multi-hole cup in the stabulum has been used, and this went on without any femoral shortening osteotomy. We managed to do this. Yet again, we see many failed trochanteric fractures with this kind of a distal femoral fixation. There is a non-union of the trochanter, greater trochanter, which is lying separately. Once you do a distal fixing stem, you need not worry much about the proximal parts. They throw out very good callus, and also you have head from this portion, so you can use the head as a bone graft. And this went on to unite well, and the patient had a good result. Bipolar, again, in a physiologically young patient, after probably 3-4 years, they may get this kind of pain, especially in an uncemented situation. So here, this was an elder lady, obese. So we went on and did a cemented stem and cemented cup, so completely cemented. But we went on to do a long stem. We might have got away with even a regular stem, but we had kept this for if in case we need to do a ETO. So this way, this patient was mobilized very early, and the elder lady, she could immediately walk after the second surgery. Similarly, we do see a lot of proximal femoral nails. We see this Z dislocation of the screws proximally and cutout of the screws, and sometimes they may go into the acetabulum also. Here again, because the patient was 84 years old, we had done a cemented bipolar for this patient and wired the trochanter and used the parts of the head as bone graft and went on to heal well. So this is a case of intertrochanteric fracture with the subtrochanteric extension, large lesser trochanteric fragment, failed surgeries many times. First, proximal femoral plate was used, failed miserably. It was in varus. Then again, blade plate device was used, which again didn't work. And finally, we had to do bipolar hemiarthroplasty, bipolar long stem with a distal fixation. Here again, make sure the screw holes are crossed with this implant. The very interesting patient who had ankylosing spondylitis. He has had his left hip replaced at the age of 28, which became loose. Then I did a revision for him. He had a fracture and he went somewhere else, and he had this kind of a fixation. From day one, the fixation was not good. So all the screws, everything broke. So here planning becomes very important on how to do this patient. You need to have a long stem, definitely. So will you get a distal fixation? Yes, maybe, but then you have to cross all the screw holes. And what about his ankylosis at the hip? you will have to, the screws are broken and present there. So it may be difficult to remove that, to chip away from the acetabulum and slowly ream, and then you need to retain as much bone as possible in the proximally, because he's still only 46. So we went ahead and we used a modular revision stem, which had a possibility of having a distal fit, and also proximally we did kind of like an ATO and split the proximal femur, chipped into the acetabulum, chipped the head out slowly and reamed it away. And those days we didn't have dual mobility liners, so we have used a constrained liner because the soft tissue tension was not good. So this went on to heal very well. Unfortunately, this patient's woes didn't get over. 3 months back, he fell down again and he had a fracture of the distal femur, proximal tibia. He had a road traffic accident, and this was fixed also. He's now currently being followed up for that. So this is the other side also, which had loosening. The initial stem was a Muller stem, and now it has been revised with a distal loading long solution stem. This is as such not a conversion THR, but probably a revision. But I thought I'll just show this image so that here we have a long plate distally, which is you need to cross that, and is an old gentleman, 70 odd years old. And how are we going to get a distal fixation? How are we going to remove the cement? Because he's had a periprosthetic fracture. It is there is some canal also is not proper. So, and also you can see the acetabulum is loose. There is polyethylene where the head is migrated proximally. So here we didn't have a choice but go on for a trochanteric osteotomy, remove the implant, remove the cement, and then we had used the reef kind of prosthesis where because we may not get a distal fixation very well, we had used these reef processes where you can put a couple of locking screws also. And proximally, we have used a jumbo cup with a peripheral hole cup where we had used peripheral hole screws also. And we had used much of allografts. We had got at least 3 or 4 heads, and we had put it all on the proximal part of the femur. The patient went on to heal well. Acetabulum fracture, this kind of a central fracture dislocation didn't do very well initially with only a posterior fixation. Probably anterior should also be done. But here we went on and did with the allograft and the patient's own head, we filled up the acetabulum and a multi-hole cup was used. Here in the acetabulum, I'll always be keeping any other devices like ring, Muller ring, or you need to do GANS processes. Everything has to be kept ready before you're going inside. Again, this is a periprosthetic fracture with a bipolar. Another challenge when there is loosening in the proximally. We went on to do a monomod stem total hip replacement. Monomod is our Dr. Vijay Bose's invention. This is a very good stem in these situations. We just wired the fracture and converted it into a revision THR. Similarly, here another periprosthetic fracture and a total hip replacement. Acetabulum seemed fine, so we went on to only do ETO, removed the cement and removed the stem, and then did the monomod, retaining the same acetabulum. Broken processes again can be a challenge, so it can be removed either from endofemoral or you can do from extraction from antegrade approach or retrograde. You can, if possible, you can, if it is loose, you can remove it from antegrade or retrograde. And antegrade fails, you'll have to go through the knee or make a small window and hit out the implant. So here you may go through a femoral nail portal from the knee or intramedullary rods. Hello? We are fine?
Carry on, Sathish.
Sorry, yeah. Is the time okay, sir? I'm okay.
No, carry on, no problem. Yeah.
Right, sure. Sometimes a broken implant can be pushed distally, and if it's very small, you can use it as a cement restrictor and go on to do a cemented total hip replacement. So extraction of the process, you'll require some special devices like bone hooks, universal extractor, etc. And gently you'll have to remove it through the medullary canal. Make sure you don't break the bone again. So in case of cortical erosion, a false tract may be there. So use C-arm, be very careful. The endofemoral approach, again, it may be tedious and time consuming. So you will probably better off going on to do a transfemoral approach, which is the sliding trochanteric osteotomy, extended trochanteric osteotomy, or distal fenestration, where you just remove a small cortex to remove the broken implant, and then you can bypass that with a long distal fixing stem. So this is briefly about ETO. I have a small video. If there is time permits, I will play the video also. It's about 4 minutes. So here you can see after doing a trochanteric osteotomy, the entire broken implant can be seen and can be removed. So preoperatively plan to which level you need to go on the X-ray, and then intraoperatively measure it and take it out. So this is a video. So this for a bipolar process which is being revised. You go through the usual posterior approach. So once you have all this thing, so here the extended trochanteric osteotomy, it is important to retain all the soft tissue attachments. Like I said earlier, you need to measure how much you need to go and mark all where you are going to make the distal end of your trochanteric osteotomy is going to be. And once you have marked it, make cuts there. Do not elevate the entire portion, just only where you are cutting. And make drill holes. So once you have marked everything properly, again with the diathermy, make drill holes. Connect the drill holes with the osteotome, with the saw, oscillating saw. Just distal to the sliding osteotomy, keep a wire ready when you're going to put the implant and you're going to ream. There is a very good chance the osteotomy may propagate lower down. So it's better to keep a wire, keep it ready, and once you've made the osteotomy, you can tie the wire before you're reaming. Sorry. So again, make sure you bevel the edges, and in the lower edge, do not make it into a right angle. Make it a slightly curved so that there is no propagation of the fracture of the crack. So with use gentle nudges with the broad osteotomes, 1 or 2, you gently open out this fracture, this osteotomy, and then you can see the entire implant right beneath you. Again, very important to leave all the soft tissues attached so that there is. So you tighten this before you remove it, and you're doing all the procedures. Once you're done with your reaming, once you're done, you can make sure all these are tied up with SS wires and tied together with cables. So canal preparation is also very important. Any residual infection or fibrous loosened tissues may be it has to be removed. This can be future source of infection, or they can be future source of loosening, and may not be bone, may not be growing into the implant if you leave any of this fibrous membrane, and has to be removed meticulously. So you can even put an endoscope inside and see and remove it. Coming to the approach, you can do whichever approach you're comfortable with. The anterior approach, if you can do an external trochanteric osteotomy with the anterior approach also. I am more comfortable with doing that. So it doesn't matter whichever approach you're comfortable, you can do this kind of things. So some of the tips and tricks here is to avoid situations where the tip of the stem is just located at the area of the screw holes. Cross these, so because this can be a stress razor and it may cause periprosthetic fracture. Previous screw holes, if you're using a cemented stem, should be closed. Otherwise, cement can seep through and sometimes can cause neurovascular damage. With an incomplete medial wall of the proximal femur, then the femoral car defect, probably use a long stem with the calcar replacement processes. Use a modular distally fixing cementless stem in the management of failed intertrochanteric fractures most often, but some authors suggest using a standard stems as long as the holes are closed with cement and there is no seepage of the cement also. Some of the complications of conversion THR is intraoperatively, there's definitely longer operative times, increased blood loss, fractures, and postoperatively, like any revision, you can have infection, loosening, hematoma, dislocation, muscle injury because you do a lot of metal removal also. Heterotrophic ossification, if you're going through anterior approach, is common. Limb length deformity, discrepancy, and medical complications because of the age of the patient and long. So this is one of the cases where there is a fracture and there's heterotrophic ossification. But being a distally fixed stem, you're very much okay to go with these because these tend to heal very well. So bear in mind there's increased operative morbidities corresponding to operation time, perioperative blood loss, and requirement of transfusion, intraoperative femoral fractures. All these complications can be there according to this study. And what is the revision rates? It's definitely more than what is there for a primary total hip replacement. You can see dislocation rate is more than 6 times that of the normal primary THR, deep infection also twice it, and periprosthetic fracture also definitely twice that of a primary total hip replacement. So in conclusion, so be prepared for a very difficult and extensile exposure. Keep all the instruments and hardware ready for removal. Altered proximal geometry is also a challenge here. So keep all the implants available, cemented, uncemented, modular, non-modular, everything, you keep it ready. The outcomes are consistent with higher instability and infection compared to primary, according to the studies. But there is no significant difference when the implant is primarily a DHS or a PFN, both have similar results. Overall, conversion THR poses greater technical challenges. The clinical outcomes remain definitely inferior to primary THRs, and complications and patient functional outcomes are similar to those following the revision THRs. Thank you all for the opportunity.
Thank you, Sathish, for a wonderful lecture. You covered all the difficult topics.
Satish, there is already a question in the question box. Can you see that?
Yeah, let me check, sir. Yes. So the question is, when we use thicker solution stem, patients complain of distal thigh pain. How much do it will be there, and what's the solution? Okay. So this solution stem and AML stem, which was previously the bullet tip stem, is known complication is thigh pain. And slowly we are all moving out of that kind of situation. Definitely, any other distal fixing stem is an option. Wagner is good. However, Wagner doesn't have the anterior bow, and I think it's universal for both right and left. So that was the reason I had been using the solution stem. I do have a couple of patients with thigh pain. Only if it's unbearable, one patient, I have revised him.
I think if there is a thigh pain, that means there is a
loosening also.
Yeah, there is
But
there is not a problem usually.
Satish, to avoid the conversion part, as you said, which is the common problem after the bipolar prosthesis, you have a cutoff limit, anatomical and physiological age, where below that you will certainly go straight away for THR?
Yes, sir. So our practice is physiological age is what we are seeing. If the patient is above 80, then we go in for a bipolar. 60 to 80, I would still prefer to do a total hip replacement, because nowadays 80 is not old. People want to have an independent lifestyle. And 60 to 80, we go in for a total hip replacement. I still do a lot of cemented hip replacements because we are able to mobilize them much earlier. Of course, medically comorbid conditions we also see. And cemented replacements also last more than 20 years. So for 60 to 80, I would prefer either a hybrid fixation or a cemented fixation. And definitely below 60, it has to be an uncemented total replacement.
Dr. Pachore, your practical tips of your experience?
I think the physiological age is more important rather than chronological age. If you active, whatever be the age, better to go for a THR.
Dr. Pachore, sir?
Yeah, I'll just come back. He mentioned, Satish, thank you for all these difficult cases and the problematic cases. But you mentioned unstable, the failed fracture in IT is maximum 9 to 10%. I think it's not true, because unstable fractures who are slightly different, especially reverse oblique, the rate of failure of your PFN nail and other things are almost 30 to 40%. So I think there's a large problem with unstable fractures. That is one important. Trochanteric fragment, you have to get back to the normal anatomy as much as possible. Reason, it will reduce the rate of dislocation and abductor limb. So it is very important to get the trochanter back, whatever the way you want to do it, but it has to done anatomically as possible. And another tip is, when there is a implant, try and expose the implant first before opening the capsule. And if you find there is some doubtful of granulation tissue or another thing, best is to take an implant and convert it to 2-stage. Don't open the capsule straight away. That is another important point. And PFN has more, conversion of PFN has more complication than DHS. DHS usually can be, the rate of complications are converting to THR are very, very low. But PFN is a real problematic, because there is a new cortices are formed around the nail, and that the entry point becomes a difficult, broaching difficult. You need a high-speed burr to burr out all the neocortices and then get back to that. That is another important. And one more very important is, dislocate the hip first before taking out the implant to reduce the stress fracture. But if there is a broken implant, we have no choice. But the implant is intact, probably you will have to try and open it and dislocate the hip, relocate, and then take out the implant, which reduces the rate of complication. These are a couple of things. And for all the youngsters around the implant, please take the culture, because you will be surprised. There are a number of patients will have some organisms, and you might have to give an extended antibiotic for these patients, in spite of normal CBC, ESR, CRP, or other things. So you need to take a culture around the implant. These are the couple of things you have to keep in mind. Regarding solution stem, yes, I agree with Satish and everybody. I think it's phased out completely. It's a cobalt chrome stem. Thigh pain is, and it is a distal loading stem with a lot of stress shedding occurring at the proximal side. And thigh pain is very, very, not very common, but is one of the entity which bothers many surgeons. Many surgeons. So the implant has been already phased out and Wagner has taken. One important point Satish mentioned, Wagner does not have, after 190, there's 225 and other, doesn't have the anterior bow, right? It is not a right and left. That is the time I think modular implant will come in the plays their role, which have the bow stems. You can use it if this anterior bow is too much. So that is another possibility of using the modular stem. Whenever there is a long stem, you need to use it. Distal blocking stems, yes. Reef is there. Initially, we had a lot of Escalab was the bicontact stem was we used to use. They are already phased out. Only interlocking stem available is a reef. When the canal is like a hose pipe and you have no fixation in isthmus, I think that's a good choice of reef prosthesis. Only thing is proximal configuration is quite big for Indians. So you be careful using a rift when you want to do it, distal lock. But distal locking stem, that is a stem is good, is a French technology, and that's a good stem as far as distal locking is concerned. Thank you, Satish.
Thank you.
And hand over to Indrajit.
Satish, there is another question there.
Indrajit?
Yes.
Huh? Question?
In conversion THR for failed IT fracture, trochanteric wiring is suggested to be done before and the trialing or after the final implantation.
No, usually normally I have described this procedure, the hip and pelvis, recently about 2 years back. We did a good number of numbers. So what we do, we mobilize and keep it where it is and before entering the new implant, we will get the vertical wires like a Chanley used to do. So use the 2 vertical wires, bring it out, after the reduction, then you start doing this wiring. So I add actually additionally the tension band device. Only wiring does not help because you need to add something else. And if the trochanteric fragment is large, we'll use the hook plate.
So you mean, sir, Dr. Pachore, sir, you are saying that you put the implant and tighten afterwards. Is that correct?
Tighten later.
Yeah.
Because it may be difficult to put the wire once the implant
it is not possible. You have to do it later on only. But you'll have to see where the trochanter is going to be and what position. But if you want to put a wires, you need to get true intramedullary wires before putting the new implant.
So one way of measuring, restoring the limb length, you have to compare to the opposite side so that you don't open or over shorten. Then you reduce the hip and then you can do the wiring. And if at all you have a problem, we can change the neck length. The trialing can be done as the last. Final head is applied. You use the opposite for restoring the limb length.
Dr. Indrajit?
Infection and osteoporosis, these are the 2 real things. They go hand in hand and most of them not really cured. So the taking up a culture, of course, is 100% necessary. And we are surprised many times by the nature of the culture and the presence of granulation tissue. So these 2 things have to be worked out very carefully. And a multi-hole cup is always should be ready. And even if we are doing a ETO, you have to be sure that the stem also is clear. Many of these cases have little granulation tissue inside this cortex in the stem. So if you do an ETO, you'll be only propagating the infection of that case. In which case, sometimes you may have to do a biopsy of this area. But usually infection is not found. It is only granulation tissue that is found. All in all, it's a very difficult case. And the other difficult ones are the ones who are waiting for a THR and then develop a fracture in the mid-shaft. That also requires a conversion THR, and I agree entirely with the long stem cemented processes, which will require a guide wire and which will require placing of that stem in the correct position.
There's one more question, sir. What do you do when there is difficulty in reduction after long-standing resection arthroplasty? When there is high-riding GT, subtrochanteric osteotomy cannot help in reduction. So here I would suggest probably you do a femoral shortening osteotomy to get it inside and use appropriate impact.
He's saying it is not helping.
Subtrochanteric femoral shortening also?
Is not helping. That's it. In that situation, we have to use a hip with very short offset, or we can do a trochanteric slide. We can slide it proximally and refix it. I've done in a couple of cases, so that will be helpful.
I think a lot of soft tissue release, because these patients do require only a lot of soft tissue release. You don't require 99%. You don't require subtrochanteric osteotomy. I'm just telling you an example of my boss, that is Dr. Dholakia. He did almost 70. That time, excision hip was very common at that time, including ankylosing spondylitis. And he did almost 70 hips, and he could bring it. But you can't do a normal normal biomechanics for these patients at all. So if you just compare the opposite side, there is some issue regarding the maintaining the biomechanics. Very rarely, I have not done subtrochanteric shortening for excision, but one of my colleagues recently has sent me. He could not reduce, and he did a subtrochanteric, and he was able to put it back. So I think that option you just keep in mind. But soft tissue release is very important. They don't behave like a DDH. They behave differently. And no type of traction preoperative. We used to do a pin traction and put them in 2 or 3 weeks in the traction. It doesn't work. So that has been stopped. So we need a good soft tissue, except gluteus medius kept intact, release everything. We almost keep the proximal femur naked. Then only it is possible. And what you say is you have to use a short neck, but the increase a little bit offset. Otherwise, dislocation rates are high.
I think we need to move Dr. Sathish.
Sure.
On behalf of Dr. Dhanasekar, my colleague, education co-chair, Dr. Indrajit Sardar, our president for the ISHKS, Dr. Pachore sir, and all the executive board and trustee members, we thank you for sparing your time and to be here for this wonderful lecture. So we thank you. Look forward to see you in Mumbai. But at the same time, let me tell all the colleagues and friends who have joined that please do register for this meeting. It's a wonderful program, academic program with lots of national and international eminent faculties. Case-based discussions there and interesting sessions are there for the novel technology. There is a very unique breakfast symposium where you can have a one-to-one discussion with the eminent faculties. So all those colleagues who have joined here today, please do register for the ISHKS meeting, which is 4, 5, 6 April in Mumbai. So once again, Sathish, thank you very much.
Thank you,
Dr. Dhanasekar, can you please welcome Dr. Vikash, please?
Yeah, thank you, Dr. Dave. Before Satish leaves, I would like to thank Satish once again. And I also like to convey my regards to Professor Devadoss, his father. He is a former TNOA president and IOA president, and he has built the Devadoss Institute at Madurai. And he's a teacher of all the present teachers. So thank you again for joining.
Thank you, Dhansek. We'll do that.
And, once again, I welcome Dr. Vikash. He's a senior consultant at Medakta Hospital in Kolkata. He's an extensive experience, 25 years experience in hip and knee orthoplasty. And he was, along with Dr. Indrajit Sardar, was helpful in organizing the ISHKS meeting at Kolkata. So once again, on behalf of our president and executive board, I welcome you all to the ISHKS meeting at Mumbai at St. Regis. And we have an excellent program. We have 10 international faculties, and we have sorted out a very good program. So I expect all of you to be there. So because we are given an interesting topic, CPAK classification, which is the buzzword now. And we are all confused whether what alignment philosophy to follow, what is right and what is wrong, what implant to use. There's so much confusion. So we'd like you to help us in understand whether CPAK classification is helpful in managing our knees. Over to Dr. Vikash.
Thank you, Dhana. Am I audible?
Yes.
Am I audible? Yeah. So I'm sharing my so is it my screen visible?
Yes, sir.
Yes, yes.
Okay, sir. Thank you. Thank you for letting me speak amongst our younger colleagues. It is truly a pleasure to be a part of ISHKS for last so many years. Um, I have tried my best to give whatever little contribution I can. So this CPAK classification is the coronal plane alignment classification, which has been last 4 years been quite extensively being discussed. And basically, this is something which is uh, sort of discussed. And initially, we all had mechanical alignment. I would fail to say initially, it almost 50 years we have been practicing mechanical alignment philosophy by Michael Freeman, and it has actually stood the test of time. We have those 20% patients who, in literature, say that they are not happy or their expectations have not been met. But then any surgery which is giving you consistently 80% results uh, is probably a surgery which is safe for the surgeons and the patients too. And that's what TKR has been. But as it is said, when you reach a certain level in your life, you always strive for more, and that's when the various different types of thought processes started coming in, whether we need to really have um, some other alignment, some other thing which we need to do to get those elusive 20% into the net, who would say that, all right, all of us are going to have the same surgery again, all of us are very happy with the surgery. So it has been a gold standard with a survivorship of 82% at 25 years, which is very, very, very encouraging result. I doubt whether many of these patients actually live that long after a knee replacement surgery. And those who do have had surgeries quite young. So as per the Indian standards, of course, nowadays surgeries are going down. They're at much younger age. People are getting bolder. They are getting operated in 40s. They don't want to live like crippled people. And so therefore, TKR is becoming more commonplace in younger people also. So this is the scope. It doesn't experience like a natural joint. 12% had persisting issues. 10% won't have this surgery again. So for these 10%, we strove to find out whether what is happening. Now, the concept of constitutional alignment, as we can see, I do a lot of other things besides joint replacement also. We do knee surgeries, HTOs, we do arthroscopies, we do footballers. Active footballers have varus knees. Excellent, excellent, and the best soccer players have had varus knees. And they've played fantastic, fantastic sports. So, and I think it is quite inherent to how they run. The physiology of running has been quite significantly good in people with varus knees, and they have played well. So this is constitutional alignment. They live with it for a very long time. But of course, they do get injured. They do have injuries and they get treated for it. And of course, in their later life, they have a lot of problems with their knees. So now there are patient-specific alignment techniques which were sort of found because mechanical alignment patients after 40 years, it became very boring for us. And it became boring in the sense that those 20 elusive percentage patients, we thought that probably we are going to doing something wrong in alignment. And therefore, various alignment techniques were worked on. You had unrestricted kinematic alignment. So first one was whatever the varus alignment or whatever the valgus alignment was, we put it in that position. The second was kinematic alignment, which was somewhere in between restricted and unrestricted. And then it became a sort of hybrid technique. From mechanical alignment, it came to adjusted mechanical alignment. So the restricted kinematic alignment and adjusted mechanical alignment kind of closed the chapter on the same page. So both of them were almost the same things. And then, of course, there was the outlier, which was the anatomical alignment, which was according to the anatomical axis of the knee. So all these alignments, and of course, if you subclassify these alignments, they became around 19 different types of alignments. And it was really confusing. Now, why did this happen? This is happening because we are trying to find a holy grail where alignment becomes the reason for satisfaction. We are looking at alignment as a singular reason for satisfaction. And that's why we are looking for alignments which are perfect. So the concept, this paper really burnt the issue which was simmering below the fire, the surface for a long time. Now, this is a very well-known paper awarded in 2011. Now, this opened up the Pandora's box. It opened up the box that mechanical alignment 00 was not the holy grail. 00 you don't get. After the surgeons realized after 20 years, 10 years, that 00 never happened really in all the patients whom we tried to give mechanical alignment. Only 20-30% of them actually landed up with a 00, and some of them were still unhappy. And therefore, it was thought that some outliers, there has to be a range. So the range came out, and the 30% of the people had a varus natural malalignment of the knee, which was equal to or more than 3 degrees. And then we realized the constitutional varus, which we had actually known, it was actually, we knew that there is a constitutional varus, but we had not documented it. This paper came out and documented it, and therefore became an awarded paper. And this, well, the consequences from pediatric orthopedics, you take up this Volkmann's law, and the concept of pressure, unequal pressure bearing can lead to a varus, constitutional varus. It came into being, and so the thought process is why these viruses happen. It happens because of this, or it happens because of genetics, or it happens in various different types of people in different countries. They are more prone to types of knees. And so restoration of mechanical alignment to neutral may not be desirable, it was thought, and it would be unnatural. So probably this was the reason people thought that we needed to look for alternative alignment. And therefore, the start happened of what are different types of alignment. Now, the distribution of the knee, as we have seen, was in varus, between varus and valgus, and HKA angle was between -2 +4 degrees. 90%, 85 to 90% of the population lie in this particular whole 500 knees, and it came out to be 1.3 degree varus in the mean HKA angle towards the varus side. And there was another variability, the joint line variability in this particular group. And here, then came after 10 years, this paper, which which measured the alignment in normal population at 25-year-olds, and in also comparatively it showed that these are the people who have similar alignments at the time when they are getting operated, similar type of, they have had constitutional varus for a long time, constitutionally different alignment of the joint, coronal plane alignment of the knee. And it went on to show that this is the whole human subset of population could be divided into 9 different types. And in these 9 different types, the basis was variability of the knee alignment and the joint line obliquity. It was McDacey and et al. Which brought out this paper and set the ball rolling. So the joint line variation is basically, joint line orientation is the addition of MPTA and lateral distal femoral angle. And therefore, as you can see in the picture, it has 3 different joint line orientations, which are apex distal, neutral, and apex proximal. If it is apex distal, it has to be, the addition sum has to be less than 180. If it is neutral, the additional sum has to be equal to 180. That is the congruent, the angles on both sides are 90 degrees, and MPTA and LDFA. And if it is apex proximal, the MPTA and LDFA sum has to be more than 180. Similarly, the arithmetic HKA is MPTA minus LDFA. So in case of varus knees, where there is a neutral alignment, a neutral joint line orientation being neutral, if the knee is in varus, then HKA is negative. If the knee is neutral, the HKA is 0. And if it is valgus, the HKA is positive. So this is the CPAK classification which they came out with. the varus, neutral, and valgus groups in the columns, and apex distal, neutral, and apex proximal groups in the rows. And in this whole program, you would see 1, 2, and 4 are, and 5, of course, are where the whole concentration, the whole gamut of population lies. Most of the outliers are in other places, and apex proximal knees are very, very, very small. So almost 70-80% of the population came in these 4 subsets of the knee alignment in coronal plane. So the aim was, so we did a research actually. We are just finishing and we just applied for this publication and I got this topic, Dhanasekar. So, our paper is, does restoring CPAK in total knee improve the patient reported outcome? We actually did a research, we've just finished this. One of my fellows has done it. And the secondary objective was assessing the phenotypes of osteoarthritic patient before and after conventional TKA using mechanical alignment, percentage of knees that obtained mechanical alignment while aiming for mechanical alignment using conventional instrumentation, and searched for any significant difference in PROMs in various cases of varus, neutral, as well as valgus knees. So here we took around 172 OA patients, did only conventional surgery. 1% of TKA most of primary total knee replacement were done by 2 of us. Most of them were done by me. And one of my junior colleagues who helped me out did some of the surgeries also in my institution. And this has been done before we started the robotics. So now, after 1 year follow-up, we have the data. And these were retrospectively included in the study with a minimum of 1 year follow-up. So minimum follow-up of 1 year and more. So exclusion criteria were these. Patients were operated with the goal of neutral mechanical alignment. So then it was to give them that middle CPAK type 5. That is what we wanted to do. CPAK grade 1 to 9 were considered, considering the ISHKS and the JLO, and was determined before and after the TKA. And functional results were assessed with the KSS, visual analog score, and forgotten joint line score. So this is what we got. We got the radiological results in HKA, preoperative varus alignment in 61% cases. We got, it was between 1 was the maximum, apex distal was the maximum, followed by 4, apex neutral varus, and followed by 7, which was apex proximal varus. So the varus group was around 61%. The neutral alignment post-operative we could achieve in this group was in HKA, in order of CPAK was 48%. And this was 5 in most of the cases, followed by 2 and followed by 8. So therefore, out of 61% where we aim to get a neutral alignment, we actually got 48% of these patients were post-operative normal alignment, neutral alignment. Similarly, considering the joint line obliquity, the apex distal were 45% in order of CPAK 1, 2, and 3 on the first row. And we got apex neutral in 58% of these patients, where it was 5, 4, and 6, as you can see. So again, if we consider joint line obliquity and we did conventional TKR, the result which we got was 58% out of this subgroup of 45% patient. Similarly, the CPAK classification, type 1 was 33%, more than type 2, which was 21%, and more than type 4 patients, which were 19%. So basically, 1, 2, and 4, 1, 2, and 4, which is neutral varus and neutral varus patients, these were 21, almost 73%, 73 or 74% patients were in either neutral or varus constitution. And we got in post-operative cases CPAK type 5 result only in 30% cases, followed by CPAK type 4 in 21% cases and CPAK type 1 in 13% cases. So this was a conventional follow-up surgery where we just looked at CPAK as one single criteria in preoperative and postoperative cases. And look, the distribution, again, this is what we get, type 1, type 5, type 4 and type 2 is where all the action is in these 4 segments. Other segments are all outliers. They are not. This is the pre-operative distribution of CPAK. And what do we get in post-operative? They come in the neutral area in type 4 and type 5 and type 1 to some extent. We can see there are as far outliers as -6 and as far outliers on +4 side. But most of the knees came between -4 to +4. And therefore, coming back to that original paper, 15 years back, which got the award, which showed that ±3 degrees or 4 degrees is where you go when you try to aim for mechanical alignment with conventional instrumentation. Well, the red ones is what we measured in our program, which we have presented in our results. So, in a restored CPAK, in places where the CPAK could be restored, we had 89 ±8 knee society scores post-operative. In unrestored, it was 87 ±8 ±7, no significant difference. In post-operative VAS, it was exactly equal. In post-operative functional joint score, after say 6 weeks, it was exactly equal. So therefore, there was no difference at all in restored and unrestored CPAK in functional results in these patients who were a significant number, 172, which could be followed up for more than 1 year, was a significant number. And so therefore, knee society scores showed no improvement, no change in knee society, VAS and FJS in CPAK restored overall versus unrestored, CPAK restored in varus knee versus unrestored. So all categories showed no change. This no improvement is the misnomer. Basically, there was no difference between the CPAK restored and CPAK unrestored. This whole effect of CPAK actually is not making any difference on the conventional. Even if we are able to restore CPAK, patients are not feeling anything happening in the within 1 or 2 years of the functional results of this particular. And our mechanical alignments have actually lasted 25 years in 80% cases. So are we looking at something longer than that or are we expecting that CPAK restored knees are going to last 25 years, 100 on 100? If that is going to happen after 25 years, then probably we would be right in saying that maybe we are doing something better by applying CPAK in this whole thing. Otherwise, as Dr. Ranawat used to say, TKR is a surgery which is meant to be reproducible in the hands of a common surgeon who does less than 40 knee surgeries a year. If you do that, and if you're able to do that, you consistently give similar results with one particular alignment technique, I think that is where we should be going instead of, and you cannot really do exact CPAK restoration before surgery. You cannot actually do a proper kinematic alignment till the time robotics have come in. You know, the amount of technology which comes in is giving us all those 2 degree. How do we quantify 1 degree virus cut and 2 degree virus cut? We do it more with robots and with navigations rather than sort of doing it with this. So these are the papers. This showed that mechanical alignment for primary may change both the phenotype and joint without influencing the clinical outcome. So it showed what we have shown with McDessie himself has shown. What we have shown in 172 knees, he has shown in 936 knees that there is no difference, except that there is slightly less post-op pain in apex distal JLO, which was restored compared to non-restored. Somebody is talking. Yeah. So impact of change in coronal plane alignment of. Hello. Impact of change in coronal plane alignment of knee on outcomes of robotic assisted TKA by our friend Rami and Mr. Agarwal, Dr. Agarwal. This is a sample size of 134. Changing patient's native joint line and CPAK classification does not change the outcome of surgery. So we had better numbers than this, which we followed up, and it has the same result which we can show. Now, some of the papers actually say that utilizing kinematic alignment plan rather than a mechanical alignment has improved outcomes in varus knees, which again, where you have a way of measuring with the help of CPAK, and therefore maybe this paper again supports some amount of Clark and Colopy paper, supports the CPAK classification's utility as a singular sort of measure for assessing the functional outcome. And of course, throwing out all other measures. I'll come to that. So, and this paper also, as recent as 24, both the papers are absolutely new and spanking, and both of them are showing that few neutral alignments are finally obtained after TKA by conventional technique. Restoring CPAK in varus knee improves PROM. Now, not a very emphatic statement to make. Why I am saying so many things is because we have ourselves done a study, and we are continuing several new studies now with robot and without robot, and trying to find out other things which are going to happen, which are happening in order to get a functional result, besides looking at only CPAK as a criteria. Because we have found that CPAK as a singular criteria has not really given any fantastic reasons for us to use it for finding out the end scores which are better. So these are again the papers classified in one particular group. And there are very few papers actually. There are not many papers still with the CPAK. A lot of work is going on. One of our work is going to hopefully come out soon. So a lot of work is being done. And I think over a period of time, we are realizing that like this one, that changing patient's native joint line and CPAK classification does not affect the outcome of surgery in terms of satisfaction. So in our study, strict mechanical alignment was achieved in 30% and neutral HK in 48%, despite aiming all knees for strict mechanical alignment. So there are so many, I know there would be a discussion that there are so many other variables. There are so many other variables which happen. The clinical relevance is that significant number of patients do not achieve neutral even after aiming for mechanical alignment in our study. And this implies that in some cases, surgeon himself performs some kind of outcome outlier to mechanical alignment involuntarily or voluntarily also sometimes in order to get a good balance in the knee and so that they have a good knee function. So restoring CPAK in neutral or valgus aligned knees also did not show overall difference in improvement in PROMs. But restoration of pre-op phenotype according to CPAK seemed to play a mild role in functional results in subset of knees, specifically in varus patients. And this result supported the studies by the Shelker and Pangart et al., who showed that neutral phenotypes, the choice of alignment strategy seemed to be of less importance than for varus or valgus knees. So basically this is a retrospective study design. We did it when we were going through CPAK 2 years back, and we were kind of thinking that let's do something on this particular. We have not, there is so much sagittal, axial planes, the rotation of the components, the rotation of femoral component, the Q angle, the rotation of variability of the rotation between the tibial and femoral component, the slope management, and there are so many other things. So CPAK as a classification, only if somebody wants to use it to improve functional result, it may be one of the things which you can use. It's a very good sort of effort to classify, but I think after 500 you need 5,000 people, maybe 10,000 people to make it more robust a study so that you have a large section. And now if we are going to use CPAK, we are going to probably see various different Asia Pacific and other places where, in Europe or in US, the alignments are completely maybe significantly different than what we have in Asia Pacific. So therefore, I think we have to have more thorough vetting of this classification. And of course, something new has come, something new has been found. McDessie has tried to classify and put a lot of effort in doing this, but it needs a lot of refinement. It needs a lot of sub-classification with various other things, including maybe rotational, the alignments, maybe sagittal alignments, and then eventually we would, with a lot of depth in research, come out with certain criteria where we can define exactly how much to have the inter-implant rotation, how much to have the sagittal place, how to look at the flexion of the components or neutrality of the components, offsets, etc. So many other things which we look at. So a significant percentage of knee doesn't achieve true mechanical alignment, despite this is a repetition of what I've already talked. And therefore, so as you can see that CPAC 1 in pre-op in 2 cases, I'm just simple cases we have just put in, goes to CPAC 2 post-operative, and the alignment comes straight and it is still close to what it was. And both of these have different HK and different JLO. As you can see, the JLO comes to from 175 comes to 179.5, and HK from -5 comes to -0.5. Similarly, CPAC 5 patients, as you can see, which has HK of 1 and 181, which is almost neutral patients, they land up with almost the same alignment, CPAC 5 to CPAC 5, and that's easy. In most of our cases in conventional surgery, when you do a CPAC 5, you go to CPAC 5. But if you do a CPAC 1, you can go to a CPAC 2, where you will have your neutral alignment, almost close to neutral alignment. But the CPAC values are changing here. So I think every knee has its own alignment story, and our goal is to bring balance with precision and care. And I think that we all should start looking at CPAC as something which is innovative. They have made an effort to classify the human population into 9 subgroups in the knee. But at the end of the day, the human population has itself got a lot of variability. So we probably need to refine this with a lot of study from different countries, and probably we can make it more robust and see what we can do with this classification in future. But I don't think yet that CPAC has that credibility to reach a place where we can say, though, no, it is a singular objective which if we meet, we will be able to give a definitely better result. And kinematic alignment or restricted kinematic or sort of a functional alignment is going to give 100% definite better result with the help of CPAC guidance against a mechanically aligned knee. I know the questions are several. I am myself doing a large set of patients with kinematic alignment with the help of robotic, and another set of patients with mechanical alignment with robotic surgery and non-robotic surgery. So we are getting into many zones and spaces. We will keep things updated. This is an ongoing research, and it's an open discussion forum now. Thank you.
Thank you, Vikash, for the wonderful message. Very nice topic. And you are doing that research, which your paper was accepted in last year ISHK meeting. So you are a good person to speak about this topic. And we know CPAC is not the one single determinant of outcome in a TKR, but being available and people addressing this, we need a guidance to what to follow. Especially in Asian patients where the lot of tibial moving, tibia vara, where the MPTA is sometimes 85 or 84, 83, where the gross joint line obliquity, restoring the CPAC will not be possible. So what is your opinion on that?
Yeah, of course, it's not possible, and that's why we have restrictions. We have a restricted alignment philosophy which has come in from. So you move away from mechanical alignment and reach a functional mechanical alignment. You move away from the kinematic alignment and you get into a restricted kinematic alignment zone, and they both land up in the same zone actually, and they end up in a apex distal CPAC alignment situation. So we have been doing this unknowingly. What I wanted to say was we have been doing this unknowingly for several decades, several decades, and that's what led to that Ranawat Award paper. And that after this classification has just put in a kind of a place where you sort of square where you can put in that particular knee and validate it. It's not that we are using this classification to get this classification is not helping us to go to the type 5 situation. This classification is telling us that okay, it was this, and we even if it has not gone to this, it has gone to this box. Now, how is it helping in this whole thing? I don't know, because it is actually not remaining in that box. So type 1 is not remaining in type 1. That is my problem. It is shifting to some other type. So whether what is right and what is wrong is a big confusion. So probably it has created a bigger confusion on the map of arthroplasty and alignment rather than anything else.
I think when we had the short films, life was easy. Once we started taking the long films, all the problems started and all the confusion was
Yeah,
started.
we took long films because we wanted to see the femoral deformities, we wanted to see the tibial deformities, we wanted to see the trauma which has happened to the proximal femur or an implant which was there. We never realized that getting into the habit of this long film for all the patients will land us in this trouble which we are in at this point of time.
Yeah, they introduced long film when they introduced the navigation system.
Yes.
They said you have to take long films and your HKA should be within 180 plus or minus 3. And we are chasing it, and we are not able to do it for many patients. And then now we understand you cannot do it for all our patients. Concept of adjusted mechanical alignment, functional alignment, and restricted kinematic alignment, all these alignments have come up. So, there is a question in the chat box.
I think 1 minute. This is not on this point, but the most neglected is the relative rotation of implants. I think we need to have we are working on a quantification of that also. We'll come up with something. Yes, the question.
Chat box, there are 2 questions for you. Which alignment technique do you use?
Well, I personally am, as I said, I'm using 3 different things now because of robot. So because of the study also which we are doing. So I am personally I am doing for last 3 months only restricted kinematic alignment, and the other colleague I've asked him to do the mechanical alignment only with the robot. So this is with robot, and without robot we are doing standard mechanical alignment philosophy. You don't have a choice there. So we are doing that. We are not doing the gap balancing technique to get the kinematic alignment with one particular knee type, the kind of implant which is there. But I think, yes, so if you ask me what I am doing for last 3 months, I am doing restricted kinematic alignment. But I have conventionally, and I still, if there is a huge like 25-degree varus and a subluxated knee, I am not doing robotic anymore. There you are straight away going for a standard mechanical alignment and releases and what we do. So there is quite a significant number of patients who are getting standard mechanical alignment surgery done also.
So you use robot for all your patients or specific patients?
50% is what in our system is getting robotics done. So there is about 40, 50 or maybe sometimes more 50 to 60 surgeries a month on robots. So which is significant in number enough to give us some data on what is happening.
Okay. So the second question there, you do tibia first or femur first?
Well, being a PCL retaining surgeon, I cut the distal femur first, and then I cut the tibial cut, and then there is you can take your extension gap, and then you go ahead in a conventional surgery. And in robotic also, I follow the same steps. It's just that the steps are the same because the philosophy is the same, the cruciate retention is the same, everything is the same, implant is the same.
So, Dr. Vikash, for the valgus knee, you said that it's a restricted kinematic. What is the principle and philosophy you follow?
So for valgus knee, you said restricted kinematic. So the restricted kinematic is the same, sir. Valgus knee beyond 10 degree valgus or something, I am not looking at robot at all. We are just
that's the point. You said that for severe varus, you do the conventional. So is it same true with the severe valgus also?
Exactly. I'm sorry. This is all varus, so therefore we are discussing that. But it holds true for both the sides. It holds true for both the sides. It's not just for one side.
I think Dr. Indrajit asked, what is the dissatisfaction level in Indian patients?
This, sir, if it is question towards me, of course, the dissatisfaction level in Indian patients or any patient, I think it is, if we have 20 dissatisfied patients out of 100 we have operated, I can be 100% sure 10 are going to be dissatisfied with all the correct parameters also. Everything happens correctly, even with the best possible alignment, they will be dissatisfied. Now, that I think is one discussion we have done several times, that we don't have a psychological evaluation, we don't have so many other things. But dissatisfaction level in my patient, I think it's not really 20%, because it is all about what we are doing before surgery. If we are telling patients that this is what is going to happen, you will have some pain, some stiffness, some swelling, all these things after some time, then they usually are expecting surgery as kind of somewhere in between normal and what they have at this point of time. So I feel dissatisfaction level in our patients still in between 10 to 15%, but dissatisfaction level is not that they are saying we will never get it done again. So they do come back for second knee. They may not be having those expectations met which they wanted. Some people have pain while sleeping. I mean, that is
I
something.
think the published literature says 10%, only 5%. Yeah.
Yeah, so between 10 to 15% is what I am saying. So it's a off the cuff remark. I have not really measured it that way.
Yeah, 10%.
If I can, Dhanasekar, there was a hello, Dhanasekar, this is Leo.
Yeah.
Yes, so there was a nice paper presented by Nilen Shah's registrar at the last ISHKS meeting. Do you remember?
Yeah, I remember that net satisfaction.
Yeah, and they're quite a large number. Of course, it's a single center trial, and they use only I think they did all manual, no robotics, and only subvastus approach. And their results were like less than 5% dissatisfaction report results.
95% were satisfied. 5%.
Less than 5% or something like that.
Yeah, but if you call your patient and ask, they're not going to say, I'm not satisfied.
I don't think
when a third party.
Yeah. That honesty, I think honestly, I don't think 5% I'll be very happy.
So, Vikash, just one question for you. You said you kind of implied that being a PCL retention surgeon, you do your femur first.
No, I take the distal femur cut first. For
the benefit of the audience, could you elaborate on what is the relationship between taking the distal femoral cut first and the PCL retention?
I'll tell you, it makes your PCL stand out prominent, and you don't cut it inadvertently when you take a tibial cut. So you have much better space which you can see your PCL. Visualize your PCL much better. And once you take a distal femoral cut, you have much more knee opened up, and your tibial cut, you can sometimes actually I go on to cut tibia in such a way, leaving a small bone island at the back where the PCL attachment starts. And then maybe release a bit of PCL on the tibial side, keeping that bone island so that I can fit in my tibial prosthesis there. Now, these are only 30% cases in which I'm able to do that. But to do that, my distal femoral cut, once I take, I get a much easier space to work in. If I don't take that cut and I cut tibia first, I would definitely notch my PCL at some place. That's it.
Agreed. Yeah.
It's a technical tip. It's not something which is related to surgery.
Number, Dr. Dipak, sir. Jai Parsuram. Yes, sir. Jai Parsuram. Jai Parsuram. Bolo. क्या होती जवान कमर बड़ा
Dipak, you have to mute your
No.
So, Dr. Dipak?
Yes, I think this was a very elaborative description and the lecture for everyone, not for the young students or the FNB or DNB, but I think it was a very nicely presented. Vikas, thank you for sparing time and coming on the live for this ISHKS program. We look forward to see you in Mumbai also.
I'm coming, sir. And
yeah.
Dhanasekar can be very persuasive. I thought that Holi was on 15th. So he reminded me that 15th is not, but in this part of the country, North India, it's a bit too much, the Holi, and a lot of people come and meet and greet and all kinds of things.
And Holi was yesterday, I think.
Was the continuity of Saturday and Sunday has become a big holiday in this part.
Especially in Rajasthan.
Yeah. So
Vikash has a lot of friends. He's still celebrating Holi. He's going back to celebrate.
I think the next month we will not be having any academic lecture program because of the ISHK meeting. And after the subsequent to that meeting, we will announce what is the plan and what is the schedule. But once again, me and Dr. Dhanasekar Raja, along with Dr. Indrajit, we all request you to please register for the ISHK meeting. It's an excellent academic program with lots of international faculties and excellent lectures, case discussion, morning breakfast symposium 1-to-1 is there. So please do register if you have not done so far. We have a huge number of papers we have received. Of course, the deadline is closed. We have already selected the papers, but it was a huge response for the paper presentation also. So with that, once again, we thank Dr. Sathish Devadoss and Dr. Vikash Kapoor, Dr. Indrajit Sardar, our president, Dr. Pachore sir, Dr. Leo, Dr. Kincha, all the senior people have joined. So me and Dr. Dhanasekar Raja thank everyone for this and have a wonderful Sunday tomorrow.
Sir, we thank you from that you have done so much of effort in the train. I can see you are sitting in a train and talking. That's amazing amount of commitment, sir. Hats off to you.
No, thank you.
Thank you, Vikash.
Thank you, Vikash. Thank you, Vikash.
Thank you so much.
Satish.
Thank you so much, Vikash. Thank you so much.
Great evening.
Thank you. Thank you.
So we look forward to see all of you in Mumbai.
Yes, see you in Mumbai. Yeah.
Okay. Dr. Pachore sir, Dhanasekar is going to send you that list, revised list.
Okay.
Yeah, I sent to sir.
Yeah. So there is no confusion. Just rewrite if you want, so that there is no confusion.
Yeah.
Give me a jam list and all other will be posters.
Yes.